Hi, good morning, everyone, and welcome. Thank you for joining us today. I'm Samantha, and I'm the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you our next installment of our webinar series brought to you by Presidia. Today, the topic is the AI effect, how AI helps deliver a single integrated platform for managing multiple at-risk programs. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You should see an attendee interface on your computer desktop in the upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit test questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during this presentation. We will collect them and address them during the question and answer session at the end of today's presentation. With that, I'm going to turn the presentation over to Mansoor.
Thank you, Samantha. Good morning, everybody, and thank you for taking the time to join us online. We're really looking forward to a nice discussion and hopefully a very illuminating and educational discussion. I have with me Kim Ham from the McLaren Health System, who will be our guest today, and we'll be talking about how they have been using AI in an integrated platform approach to managing multiple alternate payment programs that they are involved in. Kim is Vice President of Clinical Operations at McLaren Healthcare. She provides strategic direction to all of the different performance outcomes and coordination services for McLaren Health Partners, which is a large, almost 500 physician group, and they service the entire McLaren ambulatory network of over 2,600 providers. So it's a very extensive organization. And Kim has over 30 years of experience. She has a master's degree in nursing from Wayne State University and has been working in this area for most of her life. So she brings a tremendous amount of experience to the organization and to the work that she's doing at McLaren. So welcome, Kim.
Thank you. Good morning, everyone.
My name, by the way, as Samantha mentioned, is Mansoor Khan. I'm the CEO of Persivia. You know, I've been in the healthcare and the entrepreneurial business for about 20 years, and have seen a lot of changes since the early 2000s to now in terms of how we deal with healthcare and all the challenges that we have. So it's thank you for the opportunity here, and it's a pleasure to be here. Just a few words about Persivia. So Persivia serves hundreds of customers across the country, all the way from Puerto Rico to Hawaii. I think pretty much everywhere other than Alaska. We enable 3 state departments of health to do all of their disease surveillance, including COVID surveillance, through our systems. There are 7 EHRs that embed and resell parts of our solution. We serve 19 payers, over 250 hospitals, over 500 skilled nursing facilities, over 2,000 labs, and over 35,000 physicians. So Persivia, which has been around in a couple of different iterations since 2005, has a pretty significant footprint across the country and across our healthcare system. Today, we are going to be talking about the value-based care challenge and how AI is helping in address that challenge, but also how to think about AI in general. So we're going to attempt to give you a viewpoint of sort of the practical approaches and what are the different things and areas that you should be thinking about as you think about AI. I mean, there's a lot of talk about AI today, but it's not clear that everybody is on the same page. It means a lot of different things to different people. So we'll hopefully add a little bit of clarity to that discussion today. We're going to keep this a very interactive format. So we have a few slides. We're going to talk about those. And Kim and I will be sort of discussing various aspects of AI, its applications, the challenges that McLaren faced, how they address those challenges, and then we'll save about 15 minutes at the end for a question and answer period with our attendees and all our guests. So with that, Kim, I'll hand over to you so if you can talk a little bit about the McLaren environment, please.
Sure. I'll provide you with some information about our system. So McLaren Healthcare Corporation is a $6 billion system, fully integrated network. Our mission is to be the best in value in terms of quality outcomes and cost. We have 15 acute care hospitals across the state of Michigan and Northern Ohio, more than 350 ambulatory sites, and a National Cancer Institute designated comprehensive cancer center, Carmanos Hospital, and the Cancer Institute. Our McLaren Medical Group has over 490 employed providers, both primary care and specialists. We have 2 health plans located in Michigan and Indiana, and they cover over 600,000 Medicaid members. We do have multiple post-acute care services, including home care, hospice, palliative care, pharmacies, home infusion, laboratory, skilled nursing facilities, and inpatient rehab. Our network participates in a number of alternative payment models and value-based contracts. Those include an ACO, Medicare Advantage, commercial, value-based care, Medicaid, and bundled payments. We've participated both in the BPCIA voluntary and CJR mandatory. Our organization that I represent, McLaren Physician Partners, is a population health services organization. We provide services to all of our provider members. We have implemented Persivia as our population health tool. Currently integrates, if you look at the how, we've integrated over 36 different data feeds, including multiple McLaren and independent EMR clinical data, payer claims and gaps in care files, health information exchanges, and our ADT feed from our state HIE. Our care coordination services are provided by a centralized multidisciplinary staff. It's made up of RNs, MSWs, and unlicensed navigators providing services across the network. We do have some individuals who are embedded at practices and within our hospitals to help enhance those services. So a little bit about the scope of our organization and what we are trying to accomplish for this large number of patients. Next slide.
So yeah, that sort of really starts to lay out the complexity that you guys have been dealing with. And I understand, so a couple of years ago, you really started looking at how to manage across an ACO, Medicare Advantage lives, Medicaid risk, multiple commercial risk programs, the bundled payment program, CJR program, on and on and on. So very, very complicated environment across hundreds of thousands of lives. So, it'd be great if you could talk about some of the challenges that you guys faced in sort of managing that and sort of what approach you took to try and address them.
Sure. So really our first contract with the government was our ACO. And so we knew we needed to provide care coordination. It was critical that we manage skilled nursing facilities and that utilization. And so we did have multiple different systems that we were using, one for each purpose, one for care coordination, one for reporting scorecards, one as a registry. We had a separate link for ADT. And so we knew we had disparate non-integrated systems, multiple EMRs, both employed and independent providers trying to aggregate that information, as well as our Michigan payer market was adding different expectations to us that we needed more technology to apply to that. So I've listed some of the challenges here and I'll talk about them. So our care coordination was not integrated. It was just a standalone system that had some CCLF information from our ACO. And so we needed to have clinical information added there so that our staff did not have to go into multiple systems to log in. We also knew we needed to add the ADT feeds to that, as that is what drives a lot of our care coordination and pathways instead of going into a separate system. We were being asked by our payers, and we also knew we needed to risk stratify our patients. With the number of patients that we're trying to manage, we really needed to know which ones were the sickest patients, who did we need to manage first, who was going to be readmitted. And then our ADT feeds were really in a separate system. So we had to have multiple staff who could manage those lists and then input that into our care coordination system for our clinicians to begin managing patients. Our registry did have ADT or EMR feeds, but it did not organize data by payer. So we couldn't pull specific reports. It just had a limited ability to provide electronic supplemental HIEs data to our payers in the format that was being required by the different payers. And our quality reporting done by another vendor did not include all patients, all payers. And so we were running up against some payer requirements that we really needed to take action on. So we done a large search for a tool. We developed criteria in what each area would need in terms of analytics and care coordination and quality, as well as our leadership in terms of oversight reports. We needed a single platform to integrate all of these: care coordination, population health registry, and our physician performance scorecards. So our physicians only had to go to one place to look for how they were performing and then what did they need to do in terms of improvement. We also needed a solution that could scale with our large organization. We recently entered into the Ohio market, so we needed to ensure that we could scale our product selection into something that would help us with our ever-growing population, and really a partner that could help us assist with that growth, providing new technology and ideas on how we can improve our performance. And so that's really where we started our conversations with Persivia.
Great, great. Thank you. So, so that kind of leads us into the question of sort of is, so, what should a solution that is attempting to address such a complex environment be able to do, or needs to do? So I think, if I remember correctly, we had numerous conversations around sort of the level of support that a system should be able to provide in the specific areas where simplicity was the key. And I think you had made a comment about how AI should work. I don't know if you remember or not. If, do you when you talked about sort of what it should do?
Yeah. So really, from the clinician side, they really shouldn't see anything with the AI. It should lead to better processes for them, information at their fingertips, give them data elements that they need to make decisions, identify pathways that they should be utilizing. So it really should be transparent to the end user in terms of what AI is going on in the background.
Yeah, absolutely. And I think that's very critical. I always remember, back 100 years ago when electricity first came on the scene and people invented motors, people would kind of buy a motor and put it in the house and use it to run different things. So you were actually dealing with, managing this motor and kind of you're using it to run a fan at one time, using it to run a machine, refrigerator, whatever, another time, that kind of thing. And over time now, all of that gets embedded into the background, and we have so many motors in the house, nobody even knows that they're there and exist, and they just do their job. And I think that is a key factor in terms of how AI should exist and how it should use, right? AI in of itself doesn't provide value. The question is, what does it actually do that allows improved productivity, improved administrative, improved quality, reduced costs, etc. So sort of in that vein, as the old Victorian saying about children goes, kind of the opposite of that, which is AI should neither be seen nor heard. It just needs to make the provider's job easier. And to do that, it has to be able to interact with all the workflows. It must be truly embedded in the heart of the system. And one thing we've learned over the last decade and a half is that bolt-on AI, or what we used to refer in generic terms as decision support, really doesn't work. It really has to be part of the integrated workflows and the integrated approach. Trying to use sort of an external tool is really tough. And it leads to more complexity in many cases rather than less complexity from a provider's point of view. More clicks, more areas to go check, more things to do. So when we think of AI, we have to sort of think of where it can have an impact. And if properly designed, it can have impact on in multiple areas. So the three key areas are, of course, data, clinical information, and administrative areas to reduce cognitive burden. So we still, as Kim mentioned, there's over 30 or 36 data sources from where the data is coming into McLaren, and most organizations have similar levels of complexity. And so getting the data part right is still a big challenge for most organizations. I was talking to a friend of mine at another network, which is similar sized down in the South, and he said they have 400 different data feeds going in and out of their system. So they have entire organization dedicated just to managing the data. So that's one area where AI can play a very important role, which is how to take different data feeds and extract the information that you need. So information that's needed for quality management or related registries, information that's needed for HCC coding, information that's needed for care gaps. So how do you extract that information from the data stream while at the same time making sure sort of what's going on with the data stream? Like if you've got 400 or even 35, 40 data streams coming in, if one of them goes down, it's very hard for most people to know. We've seen many cases where some data stream went down for 2-3 days. Nobody realized that data stream was down, and because of that, sort of unwelcome events happened because the data was missing, and people didn't know that the data was missing. So that's one key area where AI can play a role. Another area where AI can play a role is on the clinical side. So we talked about, how do you make sure that the right clinical information is presented? So this concept of looking at the care pathway, understanding where a patient is in that care pathway based upon as much data as you can possibly get your hands on, and then making sure that you surface the right information for the providers. And then finally, the administrative part, the automation part, right? So how do you make sure that you reduce that workload? So what Kim was talking about, her team having to first log into multiple systems, then trying to figure out which information from those systems was relevant to that patient, and then trying to do something about that, right? So the tasking part of it. So one, get the right data to the right place. 2, apply clinical logic to it. And 3, create tasks and automate those tasks so they can be used, to reduce the burden, to actually help with the workflow. So, and I think, Kim, you guys had some pretty interesting experience in terms of the automation and workload and how that played. Is that correct?
Yes. So when we started with our care coordination team, I call it hunting and gathering, and that staff would spend most of their 8-hour day gathering information for the next clinician, whether it was the practice or the RN care coordinator. And with our automated processes now, they spend probably about an hour a day doing that task, and now they are actually contacting patients, helping patients resolve medication issues, referrals, and so forth. So we did experience a great deal of hours back in our day with this automation.
So So that raises the sort of the question of, right, is where should the AI reside, and how do you use that? So they're different, when people say AI, it means lots of different things in different contexts. There are different AI algorithms, that can be used. So neural networks, parts of various machine learning techniques, probabilistic graphical models, rules engines, et cetera, et cetera. And each one of those has its own place depending upon the data streams we're looking at and the kinds of activities you want to be able to do. And in most cases, you have to use multiple layers of that to achieve the goal that you want to achieve. So, when we look at data integration, for example, you have to be able to bring in the data and do various types of processing, including natural language processing, to identify key data elements. So, the AI should, for example, understand what is going on with what quality measures and quality metrics apply to a given population and a given provider group, and then be able to extract the information that is relevant for those. The same applies, for example, for HCC risk adjustment, coding support, automating workflows across care settings from acute to post-acute to ambulatory to home, creating clinical adaptive pathways. So basically understanding the patient's profile and then applying to that the care pathway that is relevant to that patient, and then surfacing the information. So when we talk about, for example, risk stratification, how do we ensure that the right risk model is applied to a given patient? Or if you're doing a care coordination workflow, as Kim was mentioning, how do you help the person doing that? And I think, Kim, you guys have done some work in task automation also, right?
Yes, we do have also some of the scoring in terms of risk stratification. It has been automated for us. We were utilizing the LACE tool and having RNs manually calculate that to determine risk and then risk stratify their population. The Persivia tool does do that for us. So it does give us the score. So the nurses are able to then just filter and organize their work and be able to select the patients at the highest risk for readmission to begin with first, and ensure that they are receiving more frequent follow-up. So we've utilized these automated tools to really drive our care pathways and how we deliver our care.
Yeah. And I think, with COVID, I believe virtual care became a big issue about a year ago for you guys. And I think, there was a lot of work done in that area also over the last 12 months, if I'm correct, right?
Yes, so as COVID numbers continued to rise, we were contacted, and it was indicated that there was availability of a COVID flag to be added to our system. We did choose to do that, being that many of our patients lived in areas that were highly hit by COVID. And so what we did is we created a pathway for COVID patients that started when the patient was diagnosed in the hospital, and then through their transition of care, and then outpatient. And so using that flag, we were readily able to identify which patients were either diagnosed or high risk. We applied the pathways and were able to deliver care. It helped us with readmissions. Based on our Michigan numbers, we were experiencing a 43% readmission rate on these patients. And so with this flag, we were really able to change the way we delivered care for those patients and ensure that they were getting the information that they needed. So that was really helpful to our group.
Yeah, and I think that's a great example of sort of how AI can help on the clinical side of things. So the ability to identify different cohorts, basically automate that identification, so the person working, the care coordinators, the care navigators don't sort of have to figure that out, right? These things are flagged for them. And I think, if I remember correctly, You are one of the first organizations in the state to really start capturing social determinants of health data and sharing it that with various entities. And I'll talk more about the complexity, but maybe first you can just give us some thoughts on sort of how you use that and what value that ability is providing.
Yes, so McLaren participated in the state innovation model, which did develop a tool that we adopted. We were utilizing that tool in a manual fashion at our practices and in our team. Persivia assisted us in developing that tool electronically, and then from that we were able to extract those data elements and format a file into the format required by our state HIE. So we are submitting that information to our state HIE, and then we'll be able to utilize that both at the state level and also with our health plans who do connect to that. So even our own McLaren health plan, we had no ability to communicate that information electronically with them. And so it allows us to share that information both at the patient level, if there is a particular need, but then also at a more global level to help the state develop resources and where are those resources needed in terms of their zip codes and locations.
Yeah. So that's a great illustration of sort of how AI can be useful, right? So in the background behind all of the capabilities that Kim just described, there is sort of a multi-step AI process going on that allows the extraction of the appropriate data. So let me sort of talk a little bit about the complexity on just this one component. So when we think of social determinants of health, there are, depending on how you describe them, about 8 major components of social determinants of health. So food insecurity, transportation issues, housing issues, income issues, et cetera, et cetera. So there are about 8 of those. Each one of those 8 can take anywhere from 30 to 150 data elements to describe fully. So if you look at the discrete data that is used to kind of describe food insecurity or housing issues, there can be anywhere from 30 to 150 data elements. And then there are, I don't know, 20, 30, 40 different organizations that are working across the country in creating their own SDOH models, using their own formats, their own terminologies. So if you kind of work all that through, it's anywhere from 30 to 50,000 different combinations in which this data could show up. Or be required to show up either way, both on the inbound and the outbound side. And so that's a huge level of complexity that's it's pretty much impossible to be managed in any manual manner. So we, our AI engine, what that does is, so it has a machine learning step in the front where the engine is trained to look at different data streams, identify the SDOH data elements, and then once it's identified them, there's a mapping step that it performs to map them to the standard, in our case, the ARC, AHRQ's standard model, and then then that data gets fed into a rules engine. So we use a multi-step AI process where there is a machine learning process up front, which generates the algorithms to identify data elements. Then it goes into a rules engine, which apply more deterministic rules that are created by physicians and clinical folks, that then says, okay, what do I do with this data? How do I need to present it? Where do I need to send it? So this is a great example of where AI can very quickly enable you to handle a new set of data, which has literally tens of thousands of possibilities, and take all of that and make it usable, so that whether it needs to go to the state through the HIE or to be shared with another care provider, all of those things become possible. And I think you guys are doing both of those, right? You're sharing it with the state as well as going to be sharing it with other providers where the patient might show up.
Correct.
And I think the HIE has their own format, so they only accept it in a specific format, and the state only accepts it in a specific format. So all of those issues are very sort of key to the ability to do that. So we talked about sort of how the tasking, how the various FTEs were able to to reduce administrative burden and convert that time into patient care. But I think I think there's some capabilities to automatically creating tasks also that goes beyond that. Is that right, Kim? Is that an area that you guys also has any improvements in?
Yeah, so we do utilize it for our emergency room visits, looking at frequent flyers. We're able to automate that in terms of workflow, notify practices that their patients were in emergency rooms versus having staff, individually faxing information. So we're able to utilize e-fax and some electronic ways to contact our providers with that important information, and then they can take action on it, reducing our need in terms of automation.
So that leads to a very sort of important question, right? About, do the dogs eat the dog food, so to speak? So how have the providers responded to that? What has sort of been their view of all these tools coming in, right? Has that improved? Are they happier, unhappier? What's kind of been sort of the feedback?
Yeah, so the physicians are definitely happier as they're getting information more real time throughout the system. So whether it's being notified of a particular event, being notified of clinical notes, their life becomes easier because it's less paper. We're able to integrate information with their electronic systems. They do appreciate more real-time communication so they can get their patients in for their transition of care visits. So we have noticed improvement in our overall rates of transition of care visits and decreasing the number of days for patients being seen, which we are starting to see decreases in our overall readmission rates. So it's kind of a trickle-down effect of, utilizing the system and having real-time information really improves outcomes.
One area that we have seen is sort of the whole burden around HIEs care gaps and RAF improvement activities. Especially with RAF and the HCC coding, AI can play a very, very key role, because as we think about sort of where the various components of HCC coding, drop codes coded by the codes that were made by other providers but not the provider that's looking at them, codes that may be extracted from clinical data, and of course information extracted from text notes, etc. Those are all all components that benefit greatly from the natural language processing part of AI. Is that an area where you guys have seen any progress, and I believe you're still working on that, but any thoughts or comments on that?
So currently, the way that we are utilizing the system, we do have some future plans for some additional technology there embedded within the EMR using extension product. But what we are utilizing is that information in terms of which specific patients might have had some condition coded the prior year, and now it's missing in the coding. And so we have a medical leadership team that works directly with the physicians to improve their performance. And we've been able to utilize this to provide them with specific cases. So we find that it's much more engaging with our physicians to give them their own particular cases to look at. And we're able to use the system to identify where those gaps exist, show them to the physician, have them have a visit with the patient and code that. So we're seeing improvement in there year over year. And then with those specific physicians that we are working with.
Yeah, that's a key area, especially if you have, I think, any Medicare Advantage life, right? There's a lot of resources that can be tied up in managing that. Yeah.
Correct. It is very time consuming with a manual system. So this is very helpful. It's also very engaging to show physicians things on screens and be able to kind of walk through that information. So it has been a great way to engage our network.
And speaking of engaging the network, one of the areas where where we've been working on was this concept of the scorecards and how to engage physicians in sort of the performance side of things, right?
Mm-hmm. Yes, McLaren has a very detailed clinical integration program and scorecards for all of our physician members. And what we were doing in the past was they would get their scorecard at the end of the period of measurement, and they had no way to take action. And it was just because we just didn't have the bandwidth to manually create these. So Persevius helped us take all of this information, customize our scorecard, and we're providing it to them real time. So they're able to see, did they meet their citizenship metrics? How are they doing on quality at that point in time? And then they can work with either their office staff if they're able to move through the system, or they can utilize our quality field staff to assist them with outreach or improving their quality. So again, taking all of this information and displaying it to the physicians in a way they can utilize it, and it's very easy for them to get to. So they are definitely finding that most useful.
Yeah. Typically, what kind of information is available in these scorecards?
So we have both citizenship information, so did they attend certain meetings? We also have quality metrics that you would be familiar with, general HIEs measures, how are they doing on cancer screenings? We also have utilization metrics in there. So we look at different medication adherence metrics. And then we also look at metrics that are more specific for our value-based contracts. So AWV rates, are they seeing their patients for their annual wellness visits, and then therefore doing the coding? Are they performing at the thresholds for transition of care? And then we also monitor network utilization. So are they utilizing our network, or are they going outside of the network?
Yeah, you know, this is actually a particularly exciting aspect, because this kind of brings, you know, I talked about AI at the data level, at the clinical level, and at the administrative level. And the scorecard kind of brings all of that together, right? So to do all of the different things that you just described about the scorecard, you have to be able to extract the data, you have to be able to apply clinical logic to it, administrative logic to it, and then produce, you know, various parameters and metrics that can then be used to populate the scorecard. So that's, you know, creating a good comprehensive scorecard that works in, you know, close to real time, if not real time, is almost, you know, you almost have to have some level of AI embedded in it, because otherwise you have a very static kind of a scorecard that won't respond when different changes occur, right? So if it's created sort of traditionally, it basically shows you what it's designed to show, and then it doesn't know what it doesn't know, sort of, so to speak. So I think that's a key area where you know, where the AI in the background sort of working quietly to process the data is a key capability. And I think this, you know, similarly for the data submission, right? There was a big challenge in sort of the output side of data, where you were submitting data to multiple payers, and that was a big burden also at some point.
Yes, for a while in Michigan, our payers were requesting data in multiple different formats. We just didn't have the ability to, you know, create all of these different formats with our analytics team. So we've been able to create those files. The system will create the files, send them to us, and then we're able to share those where they need to be. So we have a couple of different systems, both direct with payers, and then those that go directly to our state HIE, where the payers will pick up that information. So we're now able to share information with all of our payers, where before we just were able to share with a couple of them. So that has improved our, will help to improve our overall performance in the incentive plans that they have for us.
Yeah, and I believe your ACO did really well last time, right?
Yes, we did.
Yeah. I think it was like the 4th or 5th best performing ACO in the country.
Yes, the 5th.
Remember the exact ranking, but it was right up there at the very top. So I think, we're sort of coming to the end of the discussion period here. So I thought maybe we can wrap this up with talking about sort of the future. Where do you see areas for improvement? I think we had talked a little bit about discharge, the post-acute relationships, management, etc., as well as devices and telemedicine. Maybe you can share some thoughts on sort of where McLaren is going
Sure.
in the sort of near to mid future.
Sure. So we're working very hard to become a Cerner shop. We are working through our implementation, which will take us through 2022. We envision then that we will have what's called the care track, which is a EMR extension embedded in Cerner that will allow our providers to be able to identify those HCC or RAF gaps. There's some other things that we may take a look at, but we feel that is one area that will help us continue to improve our benchmarks, and then certainly improve our patient outcomes. In terms of our post-acute network, we have a network of 70 affiliated SNFs. They voluntarily join our network. They become our preferred network for all of our hospitals and discharges, and we'll be working towards an automated system and communicating with them, developing length of stay targets, ensuring that they stick to those targets, but also reducing the burden on both the skilled nursing facility and our nurse team that interact with them in terms of sharing information. We do have one pilot that's going on where we have a neighbor PO, another physician organization, that is able to log in and look at their queue of patients. It has streamlined our communication. They're able to find discharge summaries. SNFs will be able to share discharge summaries with us, and then allowing the PCP to be able to see that information. So we feel that that will put us in a very good place in terms of both financial, monitoring length of stay and that utilization, but also clinically. So we're not missing any key elements when the patients are transitioning out of skilled nursing facilities. So we do see those as two key areas that we want to look at. During COVID, we also began to use telecare coordination, which is basically telehealth, but for care coordinators, utilizing the platform. It's built right in so that the nurse is able to have a video visit with the patient, just like you would imagine telehealth. But it also has all the patient's notes right there. So the nurse isn't trying to use multiple screens and systems, and able to document that. Going forward in the future, we do have iPads that we received through an FTC grant that we are utilizing the product on. And then we've also just recently added cellular to those patients who either don't have data, internet, or availability of equipment. So we hope to grow in that area as well.
Yeah, that's actually a very, very exciting frontier, really, because when you think of that, what we started off with saying, right, that AI should neither be seen nor heard, it should just work in the background. But when we think of the devices that we really like to use, our iPhone, the very, very simple devices that are very intuitive, there's a tremendous amount of technology behind all of that to bring simplicity, right? So somebody used to say that it's much easier to write a paragraph about something than one sentence, because you can sort of just spill your brain, but you really have to think through all the issues if you're going to minimize and provide a really simple way to do things. And so when we think of sort of the discharge issues, the devices, the telemedicine, the integration into the EHR, to make that usable and user friendly to the level of say your iPhone, so that it's intuitive and it's not viewed as a burden, requires a lot of technology in the background, which is constantly processing massive amounts of data, identifying issues. So if you have devices at home and you have patients using their apps at any scale, unless you have a pretty robust system for triage all that data coming in and identifying what data is important to look at and what you can just kind of let go into the system, it can become an overwhelming burden. So I think these are areas where AI is starting to play a real key role. But again, it really has to be sort of embedded in that workflow, so everything flows through that, and it can then identify and figure out sort of what to surface to and to whom to surface and when to surface it. So I think especially when we go across organizational boundaries into the home, into the post-acute environment. Those are areas where, there's going to be some very exciting developments. And if we look at sort of the new proposals coming out of the White House as part of the infrastructure plan, they're going to put hundreds of billions of dollars into care management and into moving patients, trying to get patients to be comfortable and staying at home and, out of the institutions. I think these sorts of technologies and the ability to communicate, through Google Voice and Alexa and tie that into the clinical systems is going to become, a very, very powerful and a key capability. So I think some very exciting times coming up. So I think that's we're sort of at the transition period here into the question and answer. So Samantha, I'll hand it back over to you, and we can start the last 15 minutes or so.
Perfect. This question is to Kim. What other areas do you see your AI-driven platform playing a significant role?
So besides the ones that we've mentioned so far, we are interested in continuing to look at readmissions. We continue to identify areas that we want to take a look at. I think also looking at some additional populations, end-stage renal disease. We do have a fairly large population with that, but continuing to hone in on specific populations, which ones are at risk, having the system develop that for us so that we can then hand that off, and also working with some additional dashboards in terms of reporting capabilities. So now that we have everything kind of working the way that we want to, now we got to measure and see where are we doing well and where do we still have areas to improve.
Okay, thank you, Kim. Next question. Successful data, my window just closed. Successful data aggregation, patient matching, and presentation of the process data at the point of care and EHRs have been difficult for VBC IT platforms. How does Presidia address these difficulties currently?
Is that for me or yeah, I'll take that.
Sorry.
Yeah, so you're right. So that's a very, very key challenge, right? And sort of irrespective of all of the different interoperability requirements and information blocking issues, etc., it's still a challenge to sort of perform that last mile of integration between systems, EHRs, and other relevant systems. So there are a couple of different things that we've been doing. One is some of the EHRs, some of the bigger EHRs are deploying the FHIR standard, and they enable significant amounts of data now to be exchanged through standard FHIR-based messages. So we use those to the wherever that is possible. But we have also developed a tool we call CareTrack, which is a small application that can be downloaded either as an extension of a web browser or as a little app that runs on the desktop directly. But either way, that app is sort of integrates into the EHR and kind of is aware of what the EHR is doing. So whatever patient the physician is interacting with in the EHR, the app kind of tracks that and makes sure that all of the different types of information that we talked about, whether it's RAF scores or whether it's care gaps or whether it's device data, all of that is available in real time to the provider, and the ability to then populate the EHR with any data that the provider decides to pull in. But this is a key area that that there is there's still a lot of friction at that point, where systems that are designed to work across organizational boundaries, so inpatient, outpatient, acute, post-acute, ambulatory, home, those environments, where they need to interact with EHRs, which are primarily designed to operate either within the clinic or within the hospital, getting that data back and forth sort of fluidly is still a challenge, but it's a challenge that is that is getting a little bit better every day. So stay tuned, I guess, would be my answer to that. But but certainly point solutions are we have point solutions for specific data flows now that are pretty in pretty robust shape.
Thank you. Kim, you have stated that you have all these different payers with different quality requirements in different formats. As a large health system, why couldn't you drive the formatting or push to align the quality rather than conform to the large, I'm sorry, I lost it. To the quality rather than conform to the large variances. Sorry about that.
Well, I think one of our goals will be now that we have the ability to aggregate all of our data in one location, that we would like to see in the future where we're going to the payers and saying, here's specifically how we perform and what we would like you to incentivize us. Being in Michigan, Blue Cross Blue Shield covers about 70% of our patients that are commercial. And so we're really kind of tied to what they would like us to do. But yes, absolutely. In the future, now that we have all of our data in one location, that would be our end goal, is to really be able to go to the payers and say, here's our data and here's what we want to be measured on. Because we perform so well, because we have this all in one location, we're able to quickly monitor and react to changes.
Thank you. Mansoor, how are you able to pull the various payer data and normalize it?
Yeah, that's a interesting question. So obviously, each payer tends to have their own formatting. So over the years, we have developed an entire library of what you can call adapters that we use from different payer feeds, and we've gotten very, very good at sort of taking that information, that historical information that the team has garnered over the years, learning how to learning the sort of the nuances between the different data formats, data terminologies, different ways that the payers will generate the data, and it goes both ways, not just the incoming but the outgoing also. And what we're doing now is using machine learning to teach our systems all of that information that that our people have sort of learned over the years, and so we have terabytes of, literally multiple terabytes of data that we've processed over the years. So that data is now being used by our machine learning algorithms to look at the different feeds and select and pull out the appropriate data elements, and to, very importantly, to kind of fix the terminologies, right? So if somebody's sending an ICD-9, mapping it to ICD-10 is fine if they're sending you a standard term, but if there's if it's misspelled or it's written differently, that may not be so easy. So we're applying our machine learning algorithms to those data feeds, and then, as I mentioned before, right, there's a second step of applying a rules engine to that. So once the machine has sort of cleaned up the data and put it all in a format that is standardized, then the rules engine can kick in, and then the rules that are developed by our clinical folks and our analysis folks then start to then parse out the data and put it into the formats that can be used by other parts of the system. So it's a multi-step problem. It is the dirtiest part of our business, frankly, right? The input and output of data. That's where a lot of issues come from, and if you can solve that well, then that solves a lot of problems downstream.
Okay, great. Next question. What is the outcome against which the AI build for the physician scorecard trained against with all the data? I'm assuming that one's for you, Mansoor.
Yeah, yes, I assume that. So again, over the years, so there obviously are benchmarks, within the data for the different areas that we are looking at. So in terms of so when you look at what the scorecard is doing, right? The scorecard, even though it's sort of it's a one-page kind of a document, it actually has probably the most amount of complexity embedded behind it, because it has to deal with data issues, it has to deal with clinical knowledge issues, and it has to deal with process and workflow issues. And all of those come from different sources, right? So if the scorecard, for example, contains information about which procedures or which processes, for example, annual wellness visits for chronic care management or different types of screenings that you want to be able to track and see if, at the practice level, at the provider level, at the enterprise level, that's one set of data, excuse me, that's one set of data that we have to process for learning. For when it comes to quality measures, that's a whole different set of data. Right now, you're looking at the clinical aspects of the patient's care, right? Which procedures they had, which medications they're on, which diagnoses, what their lab values are, so on and so forth. So it's a very diverse set of data, and for the different parts of it, we have to use different data set. So there's no sort of a simple answer that that we took this one data set and did that. This has been a multi-year process. Looking at, as I mentioned, literally terabytes of data, millions of patient records, tens of millions of encounters, to sort of learn where the key points are that need to be extracted. And of course, with a lot of feedback from from clients like McLaren, who look at that and tell us, no, this doesn't mean anything, so I don't care, don't show me this, this is not relevant, but these other 3 things are relevant, and I want to see more detail on that. So it's sort of an iterative process between us and our teams and our partners.
Great, thanks. Last question is to Kim. How are you addressing self-care and the use of high-frequency data streams for patients, such as continuous glucose monitors?
So at this point, we have not integrated any of those monitors with Persivia. We are looking at remote patient monitoring. We do have a program that we use through our McLaren Health Management Group, which is our home care, home-based care. But we are currently in the process of evaluating the peripherals. What Persivia does have, though, within the data, as the nurses are looking at the information, they are able to discern where that data came from. So they're able to look at it and say, did this come from a self-reported piece of information, or did it come from the laboratory feed, or was it from, like you're saying, a continuous glucose monitor? So that part is part of our future, but we are able to, the clinicians are able to see exactly what the source of that data is, so they could work with the patient either on a lab value or on their self-reported information.
And if I may add just a little bit to that, Samantha. So the system is again, so all data streams go through the AI engine, including the device data. And from the engine's point of view, whether it's continuous device data, whether it's discrete data taken sporadically, it doesn't really matter, right? When the AI gets it, by that time it's just a data. It could be every second, or it could be once a day, or it could be once a week. But that data when it goes through the AI engine, it gets mapped against various thresholds. So all of the alerting and kind of tracking of adverse events or issues that maybe somebody needs to look at, all of that is automated. So if if it's a heart failure patient has 3 continuous days of weight gain, right, the system will generate alerts, and one of the care navigators or care managers will be notified that Mrs. Jones in such and such location, it needs to be contacted and a discussion had regarding her weight gain. So all of that part is automated, and so as new devices come on board, the system can absorb those data streams fairly readily.
Great, thank you. And thank you both, Kim and Mansoor, for this lovely presentation. And thank you everyone for taking the time to be part of our webinar. We will be sending out a follow-up email afterwards that will contain contact information. And if you have any follow-up questions, feel free to reach out. We will also provide a link to the webinar recording. Please feel free to share that link with anyone you may think may be interested. Also, I wanted to announce that we will be having a fall conference in person, November 4th and 5th in Orlando. So look for that registration to go out in the next few weeks. Again, thank you both, and everyone have a great day.
Thank you very much. Thank you, Kim, Samantha, and all the attendees.
Thank you. Have a great day.
Thank you. Bye-bye.
Bye-bye.